Well, good evening, everyone. I think we're going to go ahead and get the program started this evening. My name is Dan Coffey. I'm the President and Chief Executive Officer here at Acadia Hospital. So I want to welcome you all. We have two excellent speakers here tonight who I trust you will enjoy. This Open Mind series, we've done a number of these over the past months. We did one on the aging brain that was presented by Cliff Singer, who's a geriatric psychiatrist here at Acadia Hospital, and we also did one on cyber bullying back a few months ago. A couple of housekeeping reminders before you leave. We'd like you to take a minute and complete the feedback form. That helps us plan subsequent presentations like this. And also, we have a variety of information about Acadia Hospital, some of the programs and expertise that we have on the table up back. And we have a publication on depression from the National Institute of Mental Health. It's on the back table, and I believe we're going to send one out to each of you if you leave us your mailing address. And before we get started tonight, I also want to thank WLBZ Channel 2 and the Gannett Foundation for their help in sponsoring and helping make this event possible this evening. So without further ado, I'm going to introduce Dr. Vijay Amarendran, who's going to get us started, and his presentation will be followed by Dr. Manir Musavi later on. So again, welcome. Glad to see such a great turnout here this evening, and I'll turn it over to Dr. Amarendran. And I think I saw Dr. Amarendran's children come in. Is that right?
Right.
And his wife, right?
They came here to make sure I don't goof up. Good evening, everybody. I'm Dr. Vijay Amarendran. I'm one of the psychiatrists here at Acadia. I'm also the outpatient medical director. Thank you for being here on this evening. It's great to have you guys over. Hopefully you guys will have learn something as well as learn something interesting and have fun during the process as well. Control M.
Let's see, I think
Slideshow.
click on there. Oh, you got it. No, you didn't need my help there.
Thanks, Jim. So, I'll talk a little bit about depression. I'll start off with some interesting facts about depression and give a brief overview of the various signs and symptoms of depression. I'll also talk about the causes of depression, the various types of depression, and a brief overview of the treatment of depression, and then Dr. Musavi will talk about electroconvulsive therapy. So, why depression? Depression has been described from as early as the 4th and 5th century BC by Hippocrates. He describes this depression as melancholia. Hippocrates believed that depression or depressive symptoms were caused by bad bile or black bile. So that's where the word melancholia comes from. Melan is bad and cholia is bile. And several prominent personalities have suffered from depression. Abe Lincoln was diagnosed with melancholia. If he was alive today, he would have been diagnosed with major depressive disorder. Brooke Shields was also diagnosed, suffered with postpartum depression. She later on wrote a book about her struggle with postpartum depression and is an advocate for people to get help for depression as well. She talks in multiple national symposiums advocating for treatment of depression. Buzz Aldrin, many of you might know as the man on the moon, he also struggled with alcoholism and depression. He was one of the prominent, one of the famous people who struggled with depression. Princess Diana struggled with both eating disorder and depression. Singer Billy Joel also struggled with depression. And Kitty Dukakis, not only did she struggle with alcoholism and depression, but she also had electroconvulsive therapy for the treatment of depression, and she is a strong advocate for people to get electroconvulsive therapy. She's written a book about how ECT has changed her life. So as you can see that people from different walks of life are affected by this extremely serious illness. So depression is one of the most common illnesses, at least most common psychiatric illnesses. It's only second to anxiety disorders as far as psychiatric illnesses go. About 12 to 17% of people, the American population, struggles with depression. So the lifetime prevalence is about 12 to 17%, meaning 1 in 7 people will struggle with a depressive episode at least once in their lifetime. It's a fairly common illness. 15 million Americans are affected by depression every year. And it's also a very disabling illness. Not only is it common, it is the fourth leading disabling illness in the world. WHO, World Health Organization, did a survey in 2000, and they measured the most disabling illnesses in the world. And depression was the fourth, only next to heart disease and some of the more disabling illnesses. By the year 2020, depression is slated to be the second most disabling illness in the world, probably because we have better treatments for some of the other illnesses which kind of bumps up depression. So it's a hard illness to treat, but there are good treatments available. Depression is twice as common in women as in men. We don't understand quite the reasons why. People think it may be hormonal. Some people believe it could have biological reasons or causes for this. And also psychosocial causes explain why depression is twice as common in men as in women as in men. It's also tends to run in the families. It's 1.5 to 3 times more common in people with a family history or in people with a relative with depressive disorders as compared to people without any family history or relatives with depression. Depression can also affect all age groups. So it doesn't matter if you're 9 years old or 90 years old, it can affect any age group. So common illness can affect any age group, more common in women. And so what is depression? When people think about depression, they tend to think about a state of mind. I'm feeling sad, I'm depressed, and that's what most people think of as depression. But as a clinician or as a psychiatrist, we think about depression very different. Depression is not just a state of mind, but it's a complex neuropsychiatric illness which affects your body, your mind, chemicals in your brain. It affects the way you think, it affects your cognition, it affects your behavior. So it's a complex illness, not just a state of mind of being sad. And depression has also been associated with changes in the brain. Studies have been done comparing the brains of people, normal people and depressed people, and hippocampal volume. Hippocampus is a part of the brain which is associated with memory. And people with depression have low hippocampal volume. So it also has brain changes associated with it. So clearly it's a neurobiological illness. Also, people with depression have changes in the frontal lobe. Studies which look at blood flow to different parts of the brain show that people with depression have less blood flow to the front part, the frontal part of the brain or the front part of the brain. Another point I want to make here is some people even today believe that depression is a weakness, or I'm not strong enough to overcome my stresses. And I do want to emphasize that it is not just a weakness or a character flaw. It's clearly a biological illness with chemical changes in the brain and structural changes in the brain. So, the signs and symptoms, these are the common signs and symptoms of depression. Obviously, depressed mood or feeling low is one of the common, it is found in everybody who is depressed. Another very common symptom of depression is loss of interest. People with depression lose interest in their work. People, they lose interest in their family life, lose interest in spending time with their family, or lose interest in their hobbies. So it's a common symptom seen in depression. Sleep is also disturbed in depressed people. Most often it is lack of sleep. People have difficulty going to sleep and staying asleep. Sometimes you can also see increased sleep, where people tend to sleep a lot. So you can see both lack of sleep and too much sleep with depression. People with depression also have feelings of guilt or worthlessness. They feel responsible for everything that goes wrong around them. Everything happened because it's my fault. I deserve this way. I'm not worth this. So these feelings of worthlessness and guilt were very common in people with depression. Fatigue is also a common symptom of depression, a lack of energy or fatigue. People with depression also find it difficult to concentrate. That's why they have difficulty at work. That's why most people with depression have difficulty focusing on the task at hand and struggle and get disabled because of this particular symptom. Appetite loss or weight loss is also common in depression. Sometimes we do see the opposite. In some, rarely, we see increased appetite and increased weight loss with depression. Psychomotor agitation or retardation is a term that we use to describe people who have depression. Basically, psychomotor agitation means the movements that you observe in somebody when you talk to them. So somebody who has increased psychomotor agitation is usually restless or fidgety, can't sit still, whereas psychomotor retardation is when people just don't move much. They just stand in one place or sit in one place, look at one place constantly, don't have any movements. So you can see both psychomotor agitation and psychomotor retardation with depression. Obviously, suicidal thoughts can happen with depression. All of these symptoms that I just listed are diagnostic criteria listed in DSM-4. DSM-4 is kind of like the Bible for psychiatric diagnosis, and this is we go to the DSM-4 to make a diagnosis of any illness. So these symptoms are the DSM-4 diagnostic criteria for depression. In addition to the DSM-4 criteria, other people have other signs and symptoms of depression too, including anxiety. A lot of people with depression struggle with anxiety. A lot of people with depressive disorders have anxiety disorders comorbid with depression. So it's a fairly common symptom of depression. Irritability can be seen with depression, especially in children who present with depression. They present more often with irritability than with depressed mood. Children also tend to present more with somatic symptoms. Children are more likely to say, "Mommy, my tummy hurts," or "My head hurts," rather than say, "I'm depressed." People with depression also perceive pain very differently. They tend to perceive pain more acutely and struggle more with pain than people who are not depressed. They also have decreased sex drive, probably due to the lack of interest that is common in depression. They struggle with crying spells, which can happen with depression. People with depression also struggle with social avoidance. They tend to avoid parties, they tend to avoid meeting new people. They'd rather hole up in their room and not meet anybody. So that's also a fairly common symptom associated with depression. Low self-esteem is also can be a part of depression. So there are different types of depression. If you go back to the previous slide, the symptoms on the left, the depressed mood and all the 9 symptoms if a person has 5 of these 9 symptoms lasting for more than a 2-week period, we call it as a major depressive disorder. Major depressive disorder is a type of depression with severe symptoms of depression, usually lasting for more than 2 weeks, and can be extremely disabling and can cause loss of functioning, oftentimes requires hospitalization to treat. The other type of depression is dysthymia, which is described as a low level of depression, some of the symptoms of depression, but they are more chronic. They last for more than 2 years. That's the diagnostic criteria for dysthymia. So on the one hand, we have the major depressive disorder, severe depression more than 2 weeks. On the other hand, we have the dysthymia, low-level depression for more than 2 years. And then depressive disorder not otherwise specified as a DSM-4 diagnosis for people who don't classically fit into either major depressive disorder or dysthymia, but they still struggle with depressive symptoms. We would call this as a major depressive disorder not otherwise specified. Seasonal affective disorder is a type of depression, also called the winter blues. People with seasonal affective disorder start to struggle with depression like in the late fall, October, November, December, and progressively get more and more depressed, and the depression gets better around springtime, March, April, they get better. The treatment for seasonal affective disorder is light therapy. Basically, you have to pay the person sit in front of the light for between 30 minutes to an hour to treat seasonal affective disorder. Adjustment disorder with depressed mood is a type of depression caused by stress. Sometimes severe stress can cause people to get more depressed, and we call it adjustment disorder with depressed mood. Usually when the stressor is resolved or removed, the depression gets better. Bipolar depression is actually a subset of bipolar illness. It's very similar to major depressive disorder. It's extremely severe symptoms of depression, but longitudinally it's part of a bipolar illness where the person struggles with both mania and periods of feeling normal mood and then struggles with depression. So it's a type of, it's a subset of bipolar illness. Postpartum depression, which is what Brooke Shields suffered from. The immediate postpartum period tends to be a time of stress for moms. There's a lot of hormonal changes which happen around this time. It's an extremely stressful time for the mother. The caring for a newborn baby also tends to be stressful. And the first 4 weeks after delivery tend to be a particularly vulnerable time for moms, and they need to be screened during this period for postpartum depression. Psychotic depression or depression with psychotic features is depression associated with difficulty with reality. So people with depression can sometimes feel like no treatment is ever going to work, even though they have responded to treatment in the past. They would believe that this treatment is just not going to work for me. I know it, and you can't give me any evidence to prove, to convince me otherwise. So that's called we call it a nihilistic delusion, or so people with psychotic depression have such nihilistic delusions. And they can also have auditory hallucinations as well. Atypical depression is a type of depression where the person struggles with increased sleep and increased appetite. But most people with depression struggle with decreased sleep and decreased appetite. But people with atypical depression, which is atypical, have the opposite symptoms. Melancholic is a particularly severe type of depression associated with total lack of interest. They lose interest in hobbies, and even though they have pleasurable things happen around them, they seem to be incapable of perceiving or enjoying any pleasure. A particularly severe form of depression. Catatonic depression is a type of depression associated with paucity of movements. So this slide basically illustrates that there are several different forms of depression, ranging from dysthymia, which is some symptoms of depression which last for a long time, to major depressive disorder, which is pretty severe, to postpartum depression and psychotic depression. So there's a whole range of depressive disorders and depressive symptoms. What causes depression? So the short answer is we don't know exactly what causes depression, but we do know that depression does have a genetic component. We know that family members have a higher risk of getting depressed than somebody who doesn't have family members. Concordance, genetic studies have shown that twins who have the same genetic makeup, if one of the twins has depression, then the other twin, the chances of the other twin having depression is about 35 to 40%. So if it was 100%, we would have said, well, it's all genetic. It's clearly a genetic disease. If it was 0%, we would have said, well, it's definitely not a genetic disease. So 35 to 40% suggests that depression has genetic factors influencing it, but it's not all genes alone. It's more than genes. It's probably a combination of genetic factors and environmental factors which causes depression. Substances, substance abuse can cause depression. Almost all substances which can be abused can cause depression, including alcohol, cocaine, opiates, benzodiazepines, LSD. Any abusable substance can cause depression. Psychological stresses such as loss of a loved one can cause depression, relationship difficulties, psychological trauma, childhood trauma, neglect can cause depression. Social causes can cause depression, like people who lose their job or lose their housing or faced with severe social stresses, they tend to go into depression as well. Medications can cause depression. Blood pressure medications can cause depression. Steroids or immunosuppressant agents can cause depression. Medical causes, including strokes, cancer, any chronic medical illness can cause depression. So it's a multifactorial, multiple causes for depression. So as a result, the treatment for depression also tends to be complex and multifactorial. So for people who have like some genetic predisposition, I think we should probably go back one more slide. Now we talked about genetic factors, and the current theory of the causation of depression is that people have genes which predispose them to depression. These genes put people at different levels of risk. So there may be the low risk people, the moderate risk people, and the high risk people. And the high risk people, even with mild stresses, can go into depression, whereas the low risk people require a high amount of stresses to put them into depression. So risk factors which are affected by genes, but stress unearths or uncovers the illness. So that's how we understand depression now. So people with low risk factors are less likely to go to depression, sometimes might struggle with mild symptoms of depression. When they are stressed, they might have some difficulty with sleep and some depressed mood, but not any other symptom of depression. And these mild forms of depression can be better treated with paying proper attention to your sleep, paying proper attention to your nutrition. These factors can make a big difference. So you don't have to go in to get a psychiatrist's opinion or go into medications for such milder forms of the illness. Exercise is also has strong antidepressant properties. It releases endorphins in your brain, has been shown to have benefits in people with mild depression. Relaxation techniques can help. Yoga can help. Tai Chi can help. Our therapists here employ a variety of relaxation techniques at Acadia, including progressive muscle relaxation, where you learn to relax different parts of your muscle over time. Guided imagery, visualization, these are all examples of different relaxation techniques that therapists can teach you, and they all have antidepressant properties. Psychotherapy is one of the big mainstays of treatment of depression. Since psychological causes play such a big role in the causation of depression, psychotherapy oftentimes plays a big role in depression. A couple of types of psychotherapy have been well established to be very effective in the treatment of depression. We'll talk about this in just a couple of minutes. Medications are the other mainstay, at least from a psychiatrist or a healthcare provider point of view. The two mainstays of treatment, really, the two treatments that we can offer, are one is psychotherapy, the other one is medications. Electroconvulsive therapy is the treatment usually reserved for severe forms of depression or some forms of depression which respond better to electroconvulsive therapy. Acupuncture can help with the treatment of chronic depression as well. As far as psychotherapy goes, the two common, well-established types of psychotherapy are one, cognitive behavioral therapy, and two, interpersonal psychotherapy. Cognitive behavioral therapy was devised by Aaron Beck in the late 1970s. He observed that people with depression and also people with anxiety disorders had a certain way of thinking. They tended to have what we call as negative automatic thoughts. Let's say somebody with depression or anxiety is presented with, say, I just got the news, I'm a depressed person, I just got the news that I failed an exam. I immediately think, I'm never going to pass any exam ever again. This is always going to keep happening to me. I'm always going to be a failure. That's an example of a negative automatic thought. The negative automatic thought leads to more negative feelings or more depressed feelings. And depressed feelings, in turn, leads to negative behaviors. I'm less likely to try harder for the next exam. I'm less likely to spend more time in preparing for the exam. As a consequence, the negative behavior leads to more negative automatic thoughts, more negative feelings, more negative behavior. So the thought, behavior, emotion cycle keeps perpetuating itself. And Aaron Beck proposed that it is possible for people to observe or to self-reflect on themselves to see what their negative automatic thoughts were, and then replace the negative automatic thoughts with a more plausible or a more realistic thought. So the therapist would train me to say, well, you tend to assume that you're never going to pass this exam again, but think about the reality. If you work harder, you can pass this exam. So the realistically, or the more likely probability is there's a chance that you would pass this exam. So the therapist helps the patient reframe their thoughts. Interpersonal psychotherapy is a type of therapy devised by Harry Stack Sullivan, once again in the late 70s, early 80s. The theory behind interpersonal psychotherapy is that people with depression tend to have difficulty with interpersonal relationships. It's not that these relationship difficulties cause depression, but these relationship difficulties definitely make depression worse or recovering from depression much harder. So the goal of the therapist would be to sit down with the patient, identify the interpersonal relationship difficulties, and work with the patient on acquiring new skills to deal with interpersonal relationship difficulties. Obviously, medications are one of the mainstays of treatment of depression. Antidepressants are the first line in the treatment of depression. Among antidepressants, we have several newer agents. Probably some of you might be familiar with SSRIs or selective serotonin reuptake inhibitors. These medications increase serotonin in the brain, and people with depression have been shown to have low levels of serotonin in the brain, not only in the brain but also in the cerebrospinal fluid. Norepinephrine serotonin reuptake inhibitors, or NSRIs, are also another group of antidepressants. NDRIs, or dopamine reuptake inhibitors, such as Wellbutrin or bupropion. Tricyclic antidepressants are the older medications that we use in the treatment of depression. So these are the common examples of different antidepressants we use. If a person does not have a good response to an antidepressant, then we either try to add another antidepressant, or sometimes we add mood stabilizers, medications like lithium or Lamictal, both of which have been shown to be effective in the treatment of depression. The other group, or the category of medications that we use, are atypical antipsychotics. These were antipsychotic medications originally devised or designed to treat psychosis, But over the time, we've found that people who take low doses of these atypical antipsychotic medications, the depression gets better too. You might have seen the ad on TV about Abilify being used. It's an atypical antipsychotic medication. And when used in high doses, it treats psychosis, but in low doses, it helps with depression. Stimulants can be used if people have what we call as treatment-resistant depression, where we've tried multiple medications and the depression doesn't seem to get better. We sometimes use stimulant medications. Stimulants are used for the treatment of ADHD. Thyroid supplements, or T3, is also shown to be effective in the treatment of treatment-resistant depression. And these are the common medication treatment options for the treatment of depression. If somebody does not respond well to medications, then have a particularly severe form of depression, then we resort to electroconvulsive therapy. Electroconvulsive therapy is probably the best antidepressant that we know of. It has the most efficacy, better than any other antidepressant or psychotherapy. And another point which I should have made earlier was medications and therapy. The studies have been designed to see which ones work better for depression. Is it medications that work better, or psychotherapy that works better, or the combination? And almost universally, the combination of medications and psychotherapy has been found to be more effective than medications alone or psychotherapy alone. So it might kind of makes sense given that it's a complex multifactorial illness, so it makes sense that multiple treatments work better than one. So that's it for my part, and over to Dr. Musavi.
Good evening, everybody. I'm Dr. Musavi. First, I would like to thank you for coming. For the next 30 minutes, I'll be talking about electroconvulsive therapy. These are the topics that will be covered during this presentation. First, I'd like to talk about what electroconvulsive therapy is. It's a biological treatment. It's a somatic treatment for certain psychiatric disorders. It involves passing a small, carefully controlled electrical current through the head, which produces a seizure in the brain. The electricity is passed between two electrodes that are placed on the patient's head. Depending on the location of electrodes, ECT can be defined as bilateral or unilateral. In bilateral ECT, one electrode is placed on the left side of the head, the other one on the right side. Okay. In unilateral ECT, both electrodes are placed on the same side of the head. One is placed on the top of the head, the vertex, the other one typically on the right side, right temple. When the electricity is passed between the two electrodes, there is a generalized seizure in the brain. The seizure duration is about 30 to 60 seconds. I don't know if any of you have seen the movie One Flew Over the Cuckoo's Nest or House on Haunted Hill. In these movies, ECT has been negatively portrayed, not in movies, also in media in general. Much of the stigma attached to ECT is coming based on early treatments in which high doses of electricity were given to the patients without general anesthesia and without using muscle relaxant. Muscle relaxant is a medication. When we use this medication, it softens and significantly diminishes the body movements. So between 1940s and early 1950s, an unmodified ECT was used, meaning that there was no general anesthesia and the patient did not receive muscle relaxant. As a result, they experienced a vigorous, full-scale convulsion. It resulted in fracture, joint dislocation, injury to tongue or teeth. Today, ECT is performed under general anesthesia. Patients receive muscle relaxant, and they remain asleep throughout the procedure. They do not feel the electrical current. They do not feel any pain or discomfort. Another fact about ECT is that ECT is a standard treatment in psychiatry. National Institute of Mental Health, American Psychiatric Association, and the U.S. Surgeon General all have approved ECT as a very valuable tool in treating psychiatric disorders. ECT is a very highly effective treatment. The treatment response rate with ECT is about 80 to 90%. In all studies, ECT has been shown either as effective as medications or superior to medications. Another fact about ECT is that it works very fast. The rapid treatment response to ECT makes it a very valuable treatment and sometimes a life-saving treatment. In cases where patients are extremely depressed, highly suicidal, and they are in a psychotic state, refusing to eat, to drink fluid, ECT can be considered as the primary treatment. So the response could be seen as fast as after the first or second treatment. ECT does not cause brain damage. In post-mortem studies and studies using imaging such as MRI show that ECT does not cause any changes in brain anatomy, brain structure. In the United States, about 100,000 ECT treatments are performed each year. So I want to talk a little bit about the history of convulsive therapies in general. The history of convulsive therapy dates back to the 1500s. The Swiss physician Paracelsus used camphor by mouth to produce seizure in psychotic patients. In 1933, Manfred Seikel, a neuropsychiatrist, used insulin to treat schizophrenic patients. Initially, he used insulin to treat morphine addiction. Later, he observed morphine-addicted patients who also suffering from psychotic illnesses such as schizophrenia. After sustaining a hypoglycemic coma, their psychosis improved significantly. So he introduced insulin coma therapy as a treatment for schizophrenia. In 1934, von Meduna, a Hungarian psychiatrist, introduced chemical convulsive therapy. He used camphor, later metrazole, to induce seizure. He thought that schizophrenia and epilepsy are antagonistic disorders. Like Seikel, von Meduna noticed that epileptic schizophrenic patients, after having an epileptic attack, their psychosis is much less. So he introduced metrazole convulsive therapy as a treatment for schizophrenia. And finally, in 1938, the Italian neuropsychiatrist Saletti and his assistant Bini started using electricity to induce seizure and treat schizophrenic patients. So, as you mentioned, ECT was initially invented to treat schizophrenia, but over the time they noticed that ECT is more effective for mood disorders such as depression rather than schizophrenia. Now, ECT has been used since 1930s, but the precise mechanism of action is not fully known. It is evident that ECT produces a wide variety of effects on neurochemical, neurotransmitters, neuroendocrine systems in the brain. It may promote changes in how brain cells communicate with each other, and it may stimulate the development of new brain cells. One of the theories explaining how ECT works is called neurotransmitter neurochemical theory. This theory is based on the hypothesis that mood disorders such as depression is caused by an imbalance in brain chemicals or neurotransmitter. And ECT works through rebalancing rebalancing brain chemicals, either by increasing the level of neurotransmitter or activating their receptors. The second theory is anticonvulsant theory. Typically, during the course of ECT, the seizure threshold increases. It's interesting. ECT is the whole purpose of ECT is to produce a seizure, but as the patient goes along a treatment course, the seizure threshold goes higher and higher, and the seizure duration becomes shorter and shorter. This theory says that the episodes of mood disorder is caused by unstable brain cells. Brain cells start to fire and cause mood episodes or mood symptoms. And ECT, by increasing the seizure threshold, makes these brain cells stable, so they don't start firing and causing periodically mood episodes. The next theory is neuroendocrine theory, similar to neurotransmitter theory. It says that depression is caused by hormonal imbalances. Hormones such as cortisol, thyroxine, and sex hormones, growth hormone, are very important in how we feel. So ECT corrects the dysregulation of these hormonal systems. And the last theory that I'll be talking about is a neurotrophic theory. It's been shown that ECT does have neurotrophic properties. Dr. Amirandran talked about severely depressed patient having a small hippocampus. Hippocampus is part of the brain that is involved in memory and learning. So patients who have responded positively to ECT, the size of hippocampus normalizes, goes back to the normal size. There are some markers that would indicate brain viability. These markers are N-acetyl aspartate and brain-derived neurotrophic factor. These markers in depressed patients who have responded to ECT are increased. So when these markers increase, it shows that there is some neurotrophic event going on in the brain. I would like to talk about primary use of ECT versus secondary use of ECT. One thing that I would like to mention is that we should not keep ECT as a last resort. If patient is not responding adequately, not maintaining response to the psychotropic medication, ECT should be considered. So, primary use of ECT is when there is a need for rapid treatment response due to the severity of either psychiatric or medical conditions. Examples for these conditions are severe depression with psychotic features, when patient is catatonic, when patient is highly suicidal, refusing food and fluid. A history of positive response to ECT is another indication to consider ECT as a primary treatment. When patient is not responding to the medications or they are not able to tolerate medication side effects. When patient prefers ECT over medication. And another indication for ECT is pregnancy. ECT is much safer for the mother and the fetus during pregnancy compared to medications. Secondary use of ECT means the patient has tried all the available psychotropic medications in the market and they are not doing well and still suffering from depression. So most of patients I see for ECT consult are those who have not responded to medications. So poor treatment response to medications and or psychotherapy, intolerance of side effects, deterioration in psychiatric condition to the point when an urgent need for rapid response is present. ECT indications. ECT is a very effective treatment for depression. All types of, not all types of depression, but most types of depression. Unipolar and bipolar depression with and without psychotic features. Bipolar disorder, manic and mixed state. Schizophrenia and schizoaffective disorder. For refractory Parkinson disease. Intractable seizure disorder, because it does increase the seizure threshold, and neuroleptic malignant syndrome. Now let's talk about the ECT efficacy. The treatment response rate to non-treatment resistant depression is about 80 to 90%. For treatment resistant depression is 50 to 60%. So what does treatment-resistant depression mean? It means a patient has tried at least 2 antidepressants of adequate and therapeutic dosage and adequate duration. So if patient takes antidepressants for 1 or 2 weeks and then doesn't feel better, jumps to another antidepressant, this is not treatment-resistant. We have to make sure that patient has tried adequate dosage of adequate duration. The treatment response rate for mania is about 80%. Treatment response rate for schizophrenic patients who are acutely ill, they are not chronic schizophrenic patients, is about 40 to 80%. For chronic schizophrenia, when we combine ECT with antipsychotic medication, the treatment response rate improves significantly. The side effects and complications associated with ECT, there are some common side effects such as headache, muscle ache, nausea. There is a very rare risk of injury to tongue and teeth. We put a soft rubber guard in the mouth and protect the teeth and mouth before giving the treatment. It's listed as one of the side effects of the ECT, dislocation or bone fracture. This is extremely rare because we do use muscle relaxant. And I've been doing ECT for the past 8 years, and I've not seen bone fracture or joint dislocation. The death rate with ECT is very low. It's about 1 in 10,000 treated patients. Of course, the mortality rate is higher in patients who have multiple medical problems. The mortality rate with ECT is similar to mortality rate with any outpatient surgical procedure that require general anesthesia. There is risk of heart and lung complications, risk of heart attack, cardiac arrhythmia, risk of aspiration. There's a risk of bleeding in the brain, but these complications are very rare. Patients are carefully screened and examined before being subjected to be treated with ECT. Other complications, prolonged seizures, more than 3 minutes, or and status epilepticus. Confusion and disorientation after the treatment goes away about within 1 hour. Well, one of the important side effects with the ECT that can worry patients is the memory loss. Memory loss is related to the number of treatments. The more treatments, the higher risk for memory problem, and type of treatments, whether ECT has been done unilateral or bilateral. Bilateral ECT causes more memory problem, but it works faster. So the type of memory problem seen with ECT, one is called anterograde amnesia. It means difficulty in learning and remembering new information. So patient may not be able to remember what she or he ate the night before, or who she saw the day before. These are categorized under the new information. They may have difficulty memorizing phone numbers, new addresses, or if they read a book, they may have difficulty remembering what was in the book, what they read. This type of memory is transient, and it subsides rather quickly, within days and weeks following the ECT course. The other type of memory problem with the ECT is retrograde amnesia. It's difficulty in remembering events that have happened before starting ECT and during the course of ECT. This type of amnesia is more severe for events occurring closer in time to the ECT. Like anterograde amnesia, this type of amnesia is transient. It takes longer for this type of amnesia to resolve. So it takes about several weeks to several months following ECT to completely this type of amnesia to resolve. Of course, this resolution may not be fully complete for some memories covering the period of ECT course. And in very rare cases, some patients complain of having difficulty with memory that could persist up to months or years. Let's talk about pre-ECT evaluation. All patients receive a very comprehensive psychiatric evaluation, which includes a diagnostic clarification. because first we need to determine whether ECT is an appropriate treatment for the patient, if ECT clinically indicated. All patients require a complete physical examination. There are several blood tests that need to be obtained before starting the treatment. For patients who have multiple medical problems, we might obtain cardiology, neurology, ophthalmology consult. For patients with any brain disease, we do consider obtaining head imaging such as head MRI or CAT scan or EEG. Cognitive function, including memory performance, will be assessed before starting ECT and during the course of ECT. We also need to determine whether we need to do ECT inpatient or outpatient. Patients who are not stable, severely depressed, suicidal, psychotic, cannot provide adequate care at home, then these patients need to be hospitalized and receive inpatient ECT. Otherwise, ECT can be done outpatient as long as patient has support for outpatient ECT. The process of informed consent starts during the consultation appointment. We need to make sure that patient and family fully understands the risks and complications associated with ECT. Treatment procedure. As I mentioned, the ECT is performed under general anesthesia, so patient needs to fast overnight. They should not eat or drink anything after 12 midnight. They receive a short-acting anesthetic agent. They are asleep about 10 sometimes to 15 minutes. Once patient is completely asleep, we administer muscle relaxant called succinylcholine. And when patient is, when we obtain the full unconsciousness and adequate muscle relaxation, we give the electrical current to the patient. The treatment typically causes 30 to 90 seconds generalized tonic-clonic seizure. During the procedure, before, during, and after procedure, all the vital signs, heart rate, rhythm, blood pressure, and oxygen saturation are closely monitored. We do use an EEG monitor to determine the initiation of the seizure and the termination of the seizure. After the convulsion is over, the patient slowly recovers within 10 to 20 minutes. ECT course has two parts. The first part is called indexing or acute phase of ECT. The indexing course of ECT is about 6 to 12 treatments performed 2 to 3 times per week, Monday, Wednesday, Friday. So in order to complete an indexing course of ECT, it takes about 2 to 4 weeks. Some patients may need only 6 treatments. Some patients may need the full 12 treatments. Once symptoms are resolved, ECT is usually discontinued. However, psychiatric illnesses are chronic illnesses. They come back even though patients are on medications. They start feeling worse, getting more depressed. So ECT can be continued in the form of maintenance. For patients who are treatment resistant and have been depressed for a long period of time and tried a lot of medications and failed to respond to most medications, the continuation of ECT is recommended. If patient prefers ECT over medication, then we continue ECT. Another indication for maintenance ECT is when the patient has responded favorably to ECT and then respond poorly to the medication. This is another indication to consider maintenance CCT. When patients cannot tolerate medications, cannot tolerate the side effects of medications, this is another indication for maintenance ECT, and also patients' preference to continue ECT. The maintenance treatment starts once a week for 2 to 4 treatments, then we go to every 2 weeks, and then we go to every month. The APA guidelines recommend to continue maintenance ECT for about 6 months after completion of indexing course. And this is to prevent the relapse. So that's the last slide. And we are ready if you have any questions.
I have a question. How would the ECT affect somebody that has brain injury?
You know, I didn't put any slide on that. There is no absolute contraindication to ECT. When it comes to choosing any treatment intervention, it's always a matter of risk and benefits. So for brain-injured patients, if it's newly brain-injured patients, then we would be very cautious. We prefer not to perform ECT on a patient, with a new brain injury. But if it's not a new brain injury, yes, we can always risk and benefits. If benefits outweigh risks, then ECT should, could be indicated for the patient. Of course, patients with brain injury are more vulnerable to side effects of ECT, the memory impairment, the cognitive impairment associated with ECT. So that's one concern that we have to take into consideration. But it's not a contraindication to ECT. We can definitely do it on brain injured patients.
Thank you.
Sure. Oh, sure.
Can you explain what a seizure is?
The seizure is a rapid discharge of nerve impulses. So they start firing impulses. That's what a seizure is. That's the simplest way I can explain. So they depolarize and repolarize the brain cells. So. Do you have a better definition for seizure?
I think you did well the first thing. I think it's a rapid firing of electrical impulses from the nerve cells. And sometimes they are associated with muscle movements because the nerves supply the muscle. So the muscles also twitch when the nerves firing. Sometimes you don't see it depending on what area of the brain is affected. But the seizures that are induced by the electroconvulsive therapy have usually cause both muscle and
electrical. It has 2 components: motor seizure, which includes the movements of muscles, and the electrical seizure.
Dr. Miranda, you had mentioned that most of the causes of depression could be explained either by a combination of genetic or medical factors or external stressors or environmental things, but you both alluded to the fact that in depression, a large number of patients have measurable changes in brain volume, hippocampus volume, for instance, and brain chemicals, things that can be measured. How do you determine whether that's a cause of depression, the physical changes, the chemical changes, or the result of depression?
Well, the question is, depression has been associated with changes in your brain. Are the changes in the brain a result of depression, or is it causing the depression? And research shows that if longitudinally, if you study somebody's brain before they had depression and after they had depression, I think that would answer that question. I'm not sure if anybody has done that research study, but I'm reasonably sure that I might be able to look it up and let you know the answer. I would guess, based on what I know, I would guess that these changes are after depression. But I'll have to look into the research to answer, give you a more concrete answer to that question. That's a good question. Yeah?
You mentioned diet and nutrition.
Yes.
I've read some information lately. It says large doses of omega-3 for depression. Is that something that you...
The research studying omega-3 fatty acids and the efficacy in depression is, there have been some studies which have shown a positive response and some studies that have shown a negative response. So it's not quite clear. But we do know that they have protective effects for the heart. Sometimes we also used omega-3 fatty acids for prevention of psychosis, early psychosis, or prodromal psychosis, as we call it. So there's some research to suggest that it might help. It won't hurt to take omega-3 fatty acids. Whether it will definitely help somebody with depression, we don't know. It may.
Thank you.
Yes?
I just want to say that I don't think we're born with depression. I think it's how we're brought up by our parents. If you're brought up in a loving family, and then if you're not, I notice that people take advantage of you. You know what I'm saying? Like I've noticed when I bought a bed or when I've had something delivered, the people will try to split up and they try to take advantage of you. And then your relatives, they tell other people, and now other people are talking about you behind your back.
The
So
more,
this is what's going on. People are not, they're making the situation worse by whatever, but it's mostly from bad things that have happened to us.
the more we study depression, the more we understand it's a complex illness. A lot of different things
Yeah,
cause
people, the way we're
depression.
treated by people too, you know.
Thank you.
If we're brought up in a good and happy family, then we're not going to suffer from depression. But if we have people take advantage of us and do different things, then they're not going to get any better. Because they're talking about us behind our backs, like I said.
It's more complicated. It's more complicated than that, for sure.
If everybody was nice to everybody, we'd have a happy world.
That is true.
No, because people like to, people judge you and make fun of you and criticize you and take advantage of you, and talk bad about you behind your back.
That is true.
I just wanted to know, when you start patients on medications, you know, what is the length of time that you evaluate whether the medications are starting to be effective or not?
Antidepressants in general take about 4 to 6 weeks for maximum efficacy. So if I start somebody on an antidepressant today, I wouldn't know for sure if it is going to work or not at least 4 to 6 weeks after we started the medication. So in general, we wait about 2 months on an adequate dose of an antidepressant before we determine, okay, this medication is not working for this person, we've got to go to the next medication. So 2 months is the average time. Sometimes if there's a partial response, if it helps some but hasn't helped much, then we might wait a little bit longer and try a little bit higher dose. So, but most often it's 2 months. Does that answer your question?
Yes, I work on acute rehab,
Mm-hmm.
and know that some of our patients, with strokes and so forth, present with signs of depression. And so when you're starting to add medication and so forth, if their length of stay is not very long, then you wonder how, what is the normal expectation?
Well, stroke is a risk factor. People with stroke have a higher incidence of depression. So it seems to be a risk factor for depression. And as we talked about earlier, treatment of depression is complex. Medications are a part of it, but how they do in rehab probably plays a role. Family support plays a role. Psychological resilience plays a role. All of these play a role in the treatment. So the more treatments you can add, the better, I think.
Thank you.
Is it expected that once the medication is working well, the patient will be on that indefinitely, maybe even the rest of his life, or this is a temporary fix?
So
while other things are being sorted through? Or
Yeah,
what's
so
the
that's
goal?
another great question. How long does one stay on an antidepressant? I think the answer depends on the person, for one. If somebody has a single episode of depression, let's say this is the first time that they've ever been depressed in their life, we start them on a medication, they've responded well to medication, then if that's the case, we keep them on antidepressants for between 6 months to a year. They get better, no other symptoms of depression, they're completely back to normal baseline. We might consider tapering them off the antidepressant and see how they do. Unfortunately, a lot of times depression tends to be a recurrent illness. People with depression tend to have another episode when they get more stressed or face psychosocial stresses. In the cases of recurrent depression, somebody we know has multiple episodes of depression, then the treatment is much more long-term, long haul. So, varies from person to person.
One other question I had, it seemed like the number of different types of depression exceeded the number of treatments that are available. And I'm wondering if the treatments of those various types are so radically different that precise determination of the subtype is essential to dictate therapy, or if any one of them gets bad enough, then convulsive ECT would be appropriate, and that determining the type is more of academic interest than of practical importance.
Yeah, you're absolutely right that making an accurate diagnosis is key. It's essential for proper treatment. It's not just true for depression, it's true for any psychiatric illness. If somebody has depression and anxiety, if you don't treat the anxiety, then it's going to take much longer for the antidepressants to work. If somebody has depression and PTSD, and if you don't recognize PTSD in ad therapy or the treatment for PTSD, then it's going to be harder. So I think making an accurate diagnosis plays a big role, and different diagnoses have different treatments. Seasonal affective disorder treatment is light therapy. Bipolar disorder, the treatment would be mainly mood stabilizers. For unipolar depression, it will be antidepressant. So depending on the type of depression, the treatment will be different.
In regard to ECT, the dysthymic depression is not a good indication for electroconvulsive therapy. So if patient suffers from dysthymia, I would not recommend ECT.
So in making these diagnoses, I mean, if a given patient were for some reason to see 100 different psychiatrists independently, would all of them come to the same classification?
Well, all of them probably not, because psychiatry has really evolved over time, and we used to treat patients primarily with psychoanalytic psychotherapy. And if you talk to somebody who's 80 years old and has been practicing psychiatry for the past 50 years, they would view depression and treat depression very differently from somebody who's trained 5 years ago. So no, but that's where DSM-4 comes in play. That's where we have the Bible, so that we have the symptoms of an illness, and so that everybody agrees that these are the symptoms which will be called major depressive disorder. These are the symptoms that will be called dysthymia. This is what is bipolar. So DSM-4 will help minimize some of the differences, but it will completely take it away from now.
Do you mind if I jump in, DJ, on that one?
Yeah, go ahead. This is Dr. Singer. He's a geriatric psychiatrist. He's the one who started Open Mind series. So he's an expert in a lot of different things.
I just can't help myself jumping in here. I'm glad you talked about DSM-4 because we have those symptom-based diagnoses that sort of ignore underlying etiology or mechanisms because the science just isn't there yet. So it's really symptomatic-based treatments. The inter-rater or reliability for those diagnoses is pretty high. I think it's in the 80th, maybe close to 90 percentile. So that is perhaps 90%, 85 to 90% of people will agree on a diagnosis in this particular area. We have, for the past 20 years, been trying to find biomarkers for mood disorders. And they're just not ready for prime time. We're probably, who knows, 10 years still away from either genomic-based, gene-based, or physiologic measurement-based biomarkers. By biomarkers, I mean things that you can measure about brain function, or things that you can measure in the blood, or genetic tests that you can do. A lot of work is going into that so that we can subtype depressions accurately, or types of mood disorders accurately, and formulate very specific therapies for an individual person, just like the attempt is being made in cancer therapy. And eventually we will get there, and we've been trying for 20 years, but the science is still far away from that.
Can I have a question? Yep. With bipolar disorder, I've read that the life expectancy of a person with bipolar disorder is roughly a decade less than the general population. And I've read that in different places. Why is that? No one seems to know.
That's a tough question to answer. We do know that lifestyle plays a role in longevity. So it's possible that lifestyle adopted by people with bipolar illnesses, higher risk of high incidence of substance use, higher incidence of risk-taking behaviors, neglect to their personal health, things like that might play a role. Do we know an exact answer to your question? I don't think anybody knows the answer to that. This is exactly why people with bipolar live shorter. Yep.
Looking at signs and symptoms here, I don't see anything about anger. Does persistent, unresolved anger play a role in depression?
Irritability can be a symptom of depression. Can anger cause depression? Psychological stress induced by anger can probably cause depression. Sometimes people who adapt or don't adapt, or don't cope with anger very well, or don't cope with stresses very well, are more likely to be depressed.
I think anger is more a sign of depression rather than cause of depression. Especially in male patients, they tend to present with anger.
Anger kills. You know, because the people keep
I have a story about that, illustrates that point. This is a true story. I know a woman who's going to leave her husband because he was so grumpy. And she was depressed about the fact that her marriage was breaking up. She went to her doctor and she got a prescription for an antidepressant, Zoloft. And she gets home with it and she says, well, why should I take this? And she started putting it in his coffee. And it saved her marriage.
What was the punchline?
In closing, I think we definitely want to thank you both very, very much.